Good evening, everyone, and welcome to the second part of the 10th Masterclass on Anastomotic Leak. So those who are joining us today, those who would be watching it for the first time, Jaipur Masterclass is an extension activity of the Jaipur Surgical Tutorial, which is an online surgical education portal that we started here in the Mahatma Gandhi Medical College and Hospital 3 years ago. JST is being looked after by my colleague, Dr. Anand Nagar, who's an associate professor in HPB surgery. So two extended activities of JST. One is the masterclass, which we hold every last Thursday and Friday of the month, 2-hour session on each day. So 2 into 2, 4 hours, a single theme. In the previous classes, we have covered living donor liver transplant, safe cholecystectomy, acute and chronic pancreatitis, intensive care, ulcerative colitis, liver SOL, and some other topics. And we intend to continue this every month. And then, because the Jaipur surgical tutorial is Saturday morning, 9 to 10, but then some of the students and surgeons from Africa, they wanted a separate session or an additional session because that time was inconvenient for them. So a few months ago, we started a Friday afternoon, 3 to 4 p.m. Jaipur Surgical School, which is mainly targeted to them. Now, in most of these activities, as has been the trend in the recent past, the live online attendance is not much, but what we have seen that the views of the videos which are uploaded by the team of Dr. Avinash Tank in Ahmedabad, Dwarika Clinic, they are quite encouraging. In fact, today only I've updated the number of views of the previous master classes on various groups, and some of the master classes have had 500 and some have had even 1,000 views. So that makes us happy and satisfied. And I would request and urge all the faculty colleagues to continue to contribute to these online educational activities. So we covered some aspects of anastomotic leak yesterday. And today, the sessions will be moderated by Dr. Sastry, who is one of the senior most GI surgical colleagues in the country. He had a long stint at the Nizam Institute of Medical Sciences, and currently he's at the KIMS in Hyderabad. And he will be joined very shortly. Dr. Das just messaged me that he will be joining in a couple of minutes, by Dr. N.R. Dash, who is the professor of GI surgery at the All India Institute of Medical Sciences. And we have 3 speakers today, and then we will have an half-an-hour open house session. So with that, I hand over to Dr. Sastry. Dr. Sastry, maybe you can start and Das will join.
Yeah, sure. Good evening and welcome to the second day of the GI Masterclass. Let me first compliment Dr. Vinay Kapoor for this great initiative of his in conducting master classes on some practical subjects in GI surgery. And thanks for inviting me to be a part of the latest on anastomotic leaks. We did have some wonderful exposure yesterday to some of the aspects of anastomotic leaks, the techniques of anastomosis, the risk factors, and some specific leaks like esophageal and small intestinal leaks by reputed speakers and moderators. Today's session is devoted to the other specific leaks like colorectal anal anastomosis and the problems associated. Although there is some commonality among various anastomosis, there are specific problems for the distal anastomosis. And historically, a diversion stoma has been a part of lower rectal anal anastomosis. And it is expected to serve 2 purposes. One, to divert the fecal stream away from the site of anastomosis. And 2, to minimize the impact of an anastomotic leak if it occurs. Now, while a stoma does mitigate the clinical impact of an anastomotic leak, it comes with its own risks, that is the stoma-related complications. Now, we have Dr. Vaibhav Varshney from All India Institute Jodhpur to address these issues. Is it mandatory to have a diversion stoma in all the anastomosis? And if you have to have, what type? Ileostomy, colostomy, or any other? And a risk-benefit analysis of these. I think you would be addressing these issues. Dr. Vaibhav Varshney, please.
So while Vaibhav's slides are coming up, let me say that Vaibhav is one of the young GI surgeons who's leading a very excellent team of young faculty colleagues at AIIMS Jodhpur, and they have recently acquired a robot, and they have presented and published their experiences with robotic surgery. Vaibhav.
Thank you, sir. Thank you, Professor Kapoor, for giving this opportunity to present on this topic of proximal stoma in LAR. And thank you, moderators. So I'll start my talk, sir. Topic is whether, when, and which stoma in LAR, as Professor Sastry just briefed it. So nothing to discuss for this presentation. So why we are discussing why we need a stoma after low anterior resection? Because the most dreaded or life-threatening complication of LAR is anastomotic leak. Its incidence varies from 0 to 20% because of the varied definitions for the anastomotic leak. So there are various preventive strategies which we use intraoperatively and preoperatively to prevent this complication. So one of the complication is preoperative mechanical bowel preparation, oral antibiotics. When we talk about colonic surgeries, this role is still dubious, but for rectal surgeries, yes, mechanical bowel preparation and oral antibiotics have play a role to prevent the anastomotic leak. Second, intraoperative, testing the anastomotic integrity. Like we do jacuzzi test where we put the patient in reverse Lundberg position, pour saline in the pelvis, and with the help of Tomy syringe or normal syringe, we just push the air after clamping the proximal colon to see whether there is any air bubbles present or not. And then the perfusion study, which we usually doing nowadays, very popular with the help of endocyanine green, to see whether there is any ischemic zone present or not. If it is there, we revise the anastomosis and then do it. Then few surgeons also prefer to do anastomotic reinforcements and buttressing, taking even after doing a septal anastomosis, take some sutures at the corners to prevent the anastomotic leak, and then avoid crossing the staple lines. Creation of colonic J pouch. This means when we are doing a end to side, end of the rectum or canal and the side of the colon. That is done because they mention that the side is more vascular and there is a less tension on the mesentery. That helps in prevention of anastomotic leak. And the last is defunctioning stoma. So now we will discuss whether actually it is decreasing the severity of leak or it is actually helping decreasing the incidence of anastomotic leak. So as we discussed yesterday also, there are various risk factors of anastomotic leak after LAR. So there are preoperative, intraoperative, and postoperative. And apart from this, they can be modifiable or non-modifiable. So non-modifiable risk factors are smoking and alcohol consumptions, which are, if the patient is a chronic smoker or alcoholic, there are risk of anastomotic leakage. So we need to advise these addiction to stop before surgery. Then obesity and malnourishment, if the patient is having low BMI, low hemoglobin, less albumin, then the patient is at risk of anastomotic leakage. Then if the patient has preoperative chemoradiotherapy, again is a risk factor for anastomotic leakage. Then the vascularization of the digestive segment, as I mentioned, the endocyanine green, which can be used to see whether the bowel segment is well vascularized or not before contemplating the anastomosis. Now, second is the type of anastomosis, like whether we are doing it by hand sewn or by stapled. Mostly circular stapler is utilized. And when we have seen the literature that diameter of circular stapler has no bearing on the anastomotic leak, it is the gradual compression and firing in a proper manner is important to prevent the anastomotic leakage. Then laparoscopy has an edge over the open surgical approach in the prevention of anastomotic leakage. Prophylactic pelvic drain, some says that if there is a drain placement, there is a fluid collection there that can act as a medium for the bacteria to grow and cause anastomotic dehiscence. So putting a pelvic drain is sometimes useful. but the evidence is still debatable. Then diverting stoma, which we are going to discuss further, and the blood transfusion. If there is an intraoperative blood loss, this could be a risk factor also for anastomotic leakage. Now coming to the non-modifiable risk factors, male gender, if the patient is having comorbidities, ASA score of more than 3, again, very important factor is distance of tumor from anal verge. If it is a low-lying tumor, near to the anal verge, less than 5 centimeters, this is again a risk factor for anastomotic leakage. And then if we are doing the surgery in emergency settings, if surgeon experience is less and the intraoperative timing has increased because of various reasons like difficult anatomy or a low-lying tumor, multivessel resection. So this could be a reason for anastomotic leak. Why we are discussing all these factors are because based on these factors, we are going to take a decision. The first question of this topic is whether to do the stoma. So based on these factors, we are going to decide whether the stoma is required or not. So the next stoma is why we are discussing just make a stoma or don't make a stoma, because both the procedures, like if we make a stoma, it is again a morbid for the patient and reduces the patient's quality of life. And if we don't make the stoma and the patient's anastomosis leaks, again, this is going to cause problems to the patients by reducing the quality of life and other factors in terms of long-term survival. So if we make a stoma, so what is going to happen? The leak is become controlled, though it does not decrease the risk of leak, but the need for urgent reoperation decreases. And if we make a stoma, the problem is there is a need for second surgery. There is a longer hospital stay. And as our Sastry mentioned, it comes with stoma-related complications like stomal necrosis, stoma prolapse, stoma-related skin excoriations. So this the patient has to bear. And then complication after stoma reversal, it is noted with wound infection, small bowel obstructions, and hernia at the surgical site. And in some cases, it has also been noticed that stoma cannot be reversed despite being temporary. So making a stoma is not just a simple decision. If you don't make a stoma and there is a no anastomotic leak, the patient is the happier one. There is no need for second surgeries. Patient can go home in a very short span, a very short hospital stay, and we can start the adjuvant chemotherapy very soon. But if there is a leak, yes, there is a risk of learoplotomy, a stoma formation, percutaneous drainage to drain the collections, and then other measures for healing of the anastomosis like endosponge therapy, transanal tubes, and there are many. So when we saw the meta-analysis, we have found that you can see the diamond is favoring the divergent stoma. So in both anastomotic leak and reoperation. So they say that yes, when you do a protective diverting stoma, anastomotic leak helps in decreasing the anastomotic leaks and the reoperation rates. Further, if you see that after doing a divergent stoma, the anastomotic leak and reoperation rate are less in the no divergent group. This is contrary to the last study. So, but if you see the survival benefits, it has seen that if the patient has anastomotic leak, the long-term survival has significantly increased. But if you have done a stoma or without stoma, the long-term survival is similar. So this study favors that if you are doing a stoma, the survival is similar. And if there is an anastomotic leak, it will lead to decrease in the long-term survival. Now, the question again, does a stoma reduces anastomotic leak rate? This study, a meta-analysis of RCT have mentioned that yes, diverting or defunctioning stoma after LAR reduce anastomotic leak and reoperation rate, as I mentioned earlier also. Further, this study from Japan and other center, they are contrary to this note that divergent stoma did not reduce anastomotic leakage, but increase in the risk of post-operative intestinal obstruction. So there are both pros and cons of making a stoma. So then how to decide upon? So there is another meta-analysis of RCT from India by Dr. Pankaj Garg from AIIMS Rishikesh. He have taken 5 RCTs for this analysis, and then they concluded that divergent ileostomy in LAR for rectal cancers decreases the anastomotic leak and reoperation by 1/3 anastomotic leak and 1/4 in case of reoperation rate. So making a stoma is beneficial. Another recent meta-analysis on the same topic, the second question of our theme is when is diverting stoma is indicated from the Dr. Wexner's group. They mentioned that with diverting stoma, the complication rate is low, anastomotic leak, abscess, and reoperation is less in the diverting stoma group as compared to no diversion group. But both groups are comparable in terms of bowel obstruction, surgical site infection, and perioperative mortality. But the other factor is the mean operation time in the diverting stoma was longer than no diversion group, as obvious, because it takes time to create the stoma. So they mentioned that the factors that significantly associated with anastomotic leak in non-diabetic patients were high BMI, around more than 35, ASA more than 3, low tumor height, I mean that tumor near to anal verge, patient who have received neoadjuvant therapy, open surgery, end-to-end anastomosis, and longer operation time. So they concluded that when these factors are present, so the question is when to make a diverting stoma. So if the patient is high BMI, high ASA, low rectal tumors, neoadjuvant therapy, open surgery, end-to-end anastomosis, long operation time because of any other reason, so it is better to make a divergent stoma. So just to conclude this, when to and whether to make, if these factors are present, male patient with high age, less than 5 centimeter tumors, neoadjuvant therapy, unprepared bowel when you are doing the surgery in emergency settings for obstruction or perforation, longer operative time, intraoperative blood loss, any issue with stapler malfunction or any technical issue you have encountered intraoperatively, like positive air leak test, multivessel sections, or if patient is malnourished in the preoperative period, it is better to divert the fecal stream. Otherwise, if the anastomosis leaks happens, it is going to be very morbid for the patients, and diverting stoma will decrease the severity of anastomotic leak if it happens. So now, which stoma to make? So we have option of loop ileostomy or a transverse colostomy because the descending colon has already reached to rectum for the anastomosis. So there is no demandable superiority of one procedure over another. But in terms of complications like stoma prolapse, wound infection, and time span of stoma reversal is less with loop ileostomy. However, as obvious, the ileal effluents are liquid and the stoma output will be more in loop ileostomy group as compared to transverse colostomy. But when the patient is have marginal renal functions, so colostomy is preferred because the stoma output is more in a semi-solid state and there will be less fluid loss as compared to loop ileostomy. So there is a comparison head-to-head, and they found that loop ileostomy has low rate of leakage, wound infections, stoma prolapse, and bowel obstructions compared to loop transverse colostomy with more wound infection, bowel obstruction, and stoma prolapse. So as compared to conventional ileostomy, there are two options they have suggested to decrease the stoma-related complications, like doing a ghost ileostomy or a virtual ileostomy and a temporary percutaneous ileostomy. In ghost ileostomy, what is done is you just need to make an opening just close to the bowel into the mesentery and take this sling out at one point. So if the patient leaks in the post-operative period, then you need not to do a full laparotomy. You just open this side and just take out the ileum through this side. So will prevent the re-laparotomy in the post-op. There is an ongoing trial, RCT is going on this topic, but there are a systematic review and meta-analysis on the retrospective study that compared ghost ileostomy versus loop ileostomy, and they have mentioned that the GI versus no stoma compared to they have less incidence of anastomotic leak, and the complication grade A, B, and C are all less with GI. So GI with low anterior sections have no increased risk of anastomotic leak or post-operative morbidity compared to conventional loop ileostomy. So it's a feasible technique to prevent stoma-related complications and adverse effect on the quality of life. The other option that present is temporary percutaneous ileostomy. This is a feeding tube of 20 French to 18 French is placed in the distal ileum, 40 centimeter proximal to ileocecal junction, the site where we usually choose for loop ileostomy. This catheter is fixed to the ileal loop. And between 8 to 9 day post-op, they did a CT scan and there is no leak, then they just remove the catheter. So they found that the overall hospital stay and cost difference was significant. And they have mentioned that it is advantageous more in the elderly patients to prevent do a limited duration of fecal diversion. And there are different types of defunctioning ileostomy, which is mentioned. One is the standard loop ileostomy, one is a skin bridge, the second one is skin bridge, where they don't remove the whole skin from the abdominal wall and just leave from a rectangular patch stuck to one side, and then this skin bridge is used at the cross to the mesentery and help in stomal retraction. Then one is umbilical ileostomy, and then other method, as I mentioned, transical ileostomy, percutaneous ileostomy, and a cannula ileostomy. So to conclude my talk, anastomotic leakage, as I mentioned, is a life-threatening complications after LAR. So divergent stoma, yes, it decreases the severity of anastomotic leak and reoperation rate. So divergent stoma should be considered in patients who were at high risk of anastomotic leak. As I mentioned, all those risk factors we need to have in our knowledge when we are doing the surgeries, both pre and intraoperatively, and based on those factors, if these are present, make a diverting stoma. If they are not, then we can avoid the diverting stoma. And diverting loop ileostomy is better to transverse colostomy in time of decreased time to closure and stay in the hospitals. Gauge ileostomy and percutaneous ileostomy are options which can decrease the stoma related complications. Thank you, sir.
Dr. Sastry and Dr. Das.
Vaibhav, I think, sir, he has covered everything. We had, I think, last JST eighth version, we discussed about it, of course. And this was more extensive and you covered the evidence part very well. I don't have to comment anything on the evidence or what you said, because what you practically said is better go for a stoma when you are doing a low anterior resection, isn't it? That's what is coming out of the literature. Now, what is my practice after the experience of maybe about 20 years is I look at for what I'm doing the low anterior resection, benign or a malignant lesion. So benign for polyps, suppose I am doing, and happy with the anastomosis, I don't do any stoma. Now, there are two studies to say that if you put a perrectal catheter, soft catheter, across the anastomosis, that decompresses the air if the bowel has been prepared well, decreases the pressure in the anastomosis, and might be helping. So, over the last 10 years, I have only one leak for low anterior resection and not ultra low anterior resection. If I'm doing ultra low anterior resection, I do a stoma always, and always a ileostomy and loop ileostomy, which has proved to be better. But if you see, follow up these patients, the loop ileostomy is not a permanent, not a end ileostomy or a permanent type ileostomy. They do come back to you after a few days, some of them, that I'm passing some amount of motion down. So there is a continuity downwards. So I would say that if you're happy with your anastomosis, you can see it all around and it's healthy, then we can go ahead without a stoma. If it is a malignancy, now the question a little bit varies. First thing I take into account whether the patient is going for adjuvant therapy or not. If he has a chance of going towards for the adjuvant therapy, I invariably do a stoma and sit comfortably that nothing is happening down below, and we are safe from that point of view. Because if leak occurs or something, then the adjuvant therapy also gets prolonged, the time duration gets prolonged. Now, we have tried few cases of ghost ileostomy. Now the problem is, it is easy if you take out the loop. If you find signs of leak, you take out the loop. But what happens in the pelvis? You have to go in to drain the pelvis, and it is not so happy situation if you go percutaneously, radiologically to drain the pelvis. Uh, so ghost ileostomy, in my experience, hasn't actually helped, because if we find evidence of leak, invariably you have to go in, give a good lavage, good irrigation, and then if it is described, if there is less than 1/3 circumference gap, you can suture that one with momentum. It is there, and then form a ileostomy and come back. So that is for that. And another happy situation, if you do a stoma, is you can sleep well. Otherwise you need to watch the patient very closely for evidence of any leak, and slight pain and here and there, you think, is it a leak all the time, and you don't have enough radiological material to radiological means to show you there is a minor leak or not. And if you do a CT scan, invariably you will find little bit of collection here and there. In early phases, you find there is no leak, you sit pretty, and 2 days after, patient goes for a frank leak coming back. So these are the issues to address. But as of now, I would say, as for me, if you are comfortable enough with your anastomosis and the bowel, the tissue is healthy, you can take a chance, particularly in benign lesions. Dr. Sastry, please.
Yeah, I may be a little more conservative and, of course, older also. Are we giving a perspective that as a diversion stoma is optional after an anterior resection, low anterior resection? I see, at least till now, our teaching has been that by default, a low anterior resection should have a diversion ileostomy. The emphasis is on indications where you want to avoid, not where you want to do. That has been our perspective. Am I too old in thinking in that manner? I am particularly conscious of, say, you do what you thought as a good low anterior resection, and there is an uncertain period. There is ileus. There is no frank leak. There's no signs of frank peritonitis. An uncertain period where the patient has low-grade fever and ileus which doesn't settle. And when you do not do an ileostomy, you have a constant worry. And is a diversion ileostomy all that bad? Is the morbidity really that much? I think these are the factors you would consider. And I tend to advise the junior people who just started their low anterior resections to do a diversion procedure as a rule, as a routine. Yeah, exceptions would be different. Say when you're, like you are saying, when it's a benign problem and you are very conscious of it, and the anastomosis is a little proximal, towards the peritoneum or above the peritoneum. And in anastomosis, which are distal, definitely you would like to do a diversion ileostomy. So these are opinions do differ. I think it's important to individualize a case, and my own opinion is that by default, the procedure is a low anterior resection with an ileostomy.
Yes, I agree with you, but I have small observations, not for your comments. One is 30 to 40% of these low anastomosis can show radiological leak. Radiological, not even, they may not be clinical. Now, for that, we can't stamp that this is the proper incidence of anastomotic leak. If you exclude them, there is only 10 to 15% of cases where now it is dropping down, where you get anastomotic leak, particularly after the minimally invasive procedures. And if at all that happens clinically, we can take measures for that. For example, you can do a scopy and see the size of dehiscence or the mucosal ischemia like that, and then make the patient kneel orally and watch whether this is a small one is going to heal or not. If the condition deteriorates or the sepsis becomes more severe, you have all the option to go in and manage that. But the safest procedure for the students, I would agree what you are saying.
Yeah, I think we are going to discuss the
Yeah, we'll
leaks
move
all
on
that
and we'll
later.
keep some of these
we'll go on.
issues for the open house also, where we
Open
can
house.
request the other faculty members to come in.